So, well, we can help it, so we have to go on, and I have to start. Well, the title is MonaLisa Touch for vulvovaginal atrophy. Does it keep what it promises? So that first, I would like to answer the facts, some facts. Oh, it doesn't move. I'm sorry. No. Okay. Now you don't see it, do you? You see only the first slide, right?
Yes, we see the first slide.
Yes, but I try to put on the second one. It doesn't work. I'm sorry for that, but it really doesn't work, and I don't know why.
On this left line, you can't move.
No, I can't. I just don't see anything I can really fix in that. So only that it doesn't work.
Okay.
So
on your pad, you can't go further.
No, I can't. I'm sorry. I just I see in my presentation the changes, but I can't really. I can only just show you my main frame and hope that you can see what I'm seeing. So.
I'll see your desktop.
Oh, now you see it, right?
Yes.
So now you can
Yes.
see it. I'm sorry.
Yes, now it's okay.
Okay. So, well, at first, we should ask ourselves what is about vulvovaginal atrophy. I mean, you know all that. It's not new. We have, and it's again the problem. We have different stages of vulvovaginal atrophy, of course, and we see in the left side young epithelium, and on the right side an older non-hormonal activity epithelium cells with mostly parabasal and basal cells. And so this is a physiological aging process of the vaginal epithelium, nothing special, but very easy to diagnose. So in second, we should ask ourselves how it's in practice. So if we do a histology, we see in the vaginal epithelium on the left side some very broad cells and layers, and on the right side a very, very small intermediate and superficial layer and a very large basal layer. And if we ask ourselves how it happens, then we have to ask, well, it's mainly due to a reduced estrogen production and thinning of the epithelial cells, with less exfoliation of vaginal cells and less glycogen production from vaginal cells. This causes less intracellular glucose production and less lactic acid, with an increase of the pH and high growth of other bacteria, decrease of lactobacilli, and vice versa, less lactic acid again. So it's a circulus which is here with the decreasing of, sorry, I can show you really my laser pointer. I'm really sorry for that. So I think this is maybe because I'm using a Mac. So the next point for me is that we talk a little bit about a wording. The consensus conference of 2012 was remarkable because till then we have a genitourinary syndrome, urinary syndrome as a wording for vulvovaginal atrophy before. That means that we can express in a better way the complaints of the patients, and we can really it turned out to be more easy for us, or easier for us, to categorize that. And well, in excerpt, the symptoms of this many complaints of the patient is at first the vulvovaginal side with dryness, dyspareunia, bleeding and discharge, burning, itching. And second, we have urinary problems like an urgency or recurrent infections or incontinence. And in sexual, we have an erectile dysfunction, decrease of libido, dyspareunia, bleeding during intercourse, and anorgasmia. So many of these women have 2 or 3 symptoms at once, and it's very, very rare that we have women without one, or with only 1 or 2 symptoms. Some facts: about 15% of premenopausal women have the problems with the GUS, and women over 40 in about 85% complain of vaginal dryness, in 80% of pruritus, vulvae and vagina, and in 60% of dyspareunia. So we see that this is a very common problem, and it's, as I will show you, underestimated. We estimate about, in 2030, about 70% of the population over 65 years having problems in spite of therapy. And this is caused because we have an increase of life expectancy, and we have also an increase of demands and needs of these women. So the issue is very often underestimated, underdiagnosed, diagnosed, and undertreated. And this causes also a high risk of anxiety and depression. It's because the first thing that we see in diagnose is shame. Many women are ashamed of this complaints and of these problems they have. So they don't go to an exam, or they don't talk to their doctor. Widely in public, this problem is considered as normal in aged women. They always been told, okay, that's normal for you. And so they don't think about it. And only 4% of the women relate their symptoms they notice to the GUS. This is very remarkable, and only 25% are consulting a doctor because of this problem. 54% discuss the topic with their doctors only when they're asked. If you don't ask, they don't tell you. And 33% of the women are not complaining about their problems at all. So in differential diagnosis, it's very important to consider that there could be other problems that cause similar symptoms as the GUS. As they are infections, as they are allergic or enzymatic disorders, as there are systemic diseases like diabetes or lupus, autoimmune diseases, chronic pelvic pain, and vulvodynia, vestibulodynia, and vaginism. Chronic vaginal disorders, injury, foreign body. In elder women who live alone, and mostly we see sometimes really injuries with caused of foreign bodies, and before being too fast to diagnose a dryness on the phone and give them some cream, you should consider this. So the diagnosis is very important, because the diagnosis does the setting for an adequate patient selection for this therapy. So if you don't diagnose it rightly, you cannot choose the right patient, so your therapy will not have the effect you want the therapy to have, right? And that's why we always try to choose the right therapy options, which are hormonal and non-hormonal. The hormonal options, we know, all of us know that the local estrogens are a golden standard in the therapy, plus minus a systemic hormonal replacement therapy, or a DHEA local. Dihydroepiandrosterone is a approved treatment also in Switzerland, and it's available in suppositories. And the non-hormonal corner, non-hormonal corner, they're lubricants, moisturizers, probiotics, and the topic we want to talk today, an interventional laser application. So one could ask himself, where does it come from and why do we do it? I mean, this is a good question. And it all began with the erbium YAG and not with the CO2, because the erbium YAG lasers were earlier in gynecological use and the CO2 came later on. And all the treatments are leaned on skin therapies. So there is a differentiation to make between ablative and non-ablative mechanisms and non-ablative treatments. The mechanism is the same. It's an activation of heat shock proteins, an activation of growth factors. And through that, and because of that, it's an increase of vascularization, an increase in collagen, and an increase in extracellular production of new matrix. Vaginal thickness of the epithelium is growing less. So if we just think about the question, what is it? Is it really? Does it all what it's promised? We have to ask ourselves, what does it promise? And here we have a small discrepant development. On the one hand, we have our medical development in form of studies, and on the other hand, we have a lot of advertising and a lot of campaigns in the last years at all. So we see here campaign MonaLisa Touch, give you a boat and give you love, and the treatment is here mentioned. It's a very different campaign. So some campaigns they tell you about the treatment. The other ones, as you saw in this one, they don't tell you at all what they do. And in all these pictures, you see couples, and they look very happy. So you see sometimes here the price. This is from Indonesia, and I think it's about 600 francs per session. So this is this one, and this one doesn't tell you anything. I mean, it could be also a couple wearing white, but it's in this campaign. And this one tells you the treatment, but it doesn't tell you what for. And here you've been told what for you're doing this treatment. So what we need and what we try to achieve is evidence. And this is our problem we have now, and we have nowadays with this method, that we still trying to get really clear evidence of what it's like, what is the benefit of this treatment, what can we achieve from this treatment, and what we are doing and what we are getting and what we are doing to our patients. And the second question is, what kind of side effects do we have? And just a remark, if you have some questions, don't hesitate to put on your mic and just ask, please. So there are some studies done here, publication which is not chosen by myself because it's a Greek one. It's chosen because for me it's one of the first meta-analyses, and it's published 2017, and it includes 14 studies with 542 participants. And the conclusions were that laser therapy in genitourinary syndrome for postmenopausal women is a promising therapy and may improve quality of life by reducing symptoms severity of GUS and may restore the vaginal mucosa to premenopausal status. So in general, we see that in the last statement of this study, of this meta-analysis, was that the quality of the body of evidence is too low to modify our clinical practice, and so the authors do not suggest to change the clinical treatment of GUS. And this is evidence in 2017, and the second one is in 2020. We saw a publication of the European Journal of Obstetrics and Gynecology. This is a more UK-based study, so or a UK-based meta-analysis, and it included 19 studies with 1780 patients, mostly prospective observational studies. Follow-up mostly 3 to 6 months, in 2 studies 12 to 24 months. 3 studies were prospective randomized and sham controlled, which is very rare that we have what we have here, because very, very rarely we see really randomized studies with sham controls, and this is what we need also for the future. And the duration of therapy effect was 12 to 18 months. Very mild side effects as local edema, discharge, intravaginal pain, which vanished after a few days. It's mostly grade 1 side effects were mostly here mentioned. And well, one can discuss what happened in these 3 years. I mean, do we have now really more evidence that this is a better treatment that we have here, or is the evidence higher? And we see it's slightly higher because we've had this 3 studies and we have the longer follow-up. So it could mean that it's more trustworthy to do this therapy. We are doing this interventional laser now for 3 years, and we picked out just 22 patients randomly. What we tried to do is we tried not to do a study, but we gave out a questionnaire which is non-standardized. I'm sorry for this small fault here. And they were all treated in-house. And these patients, they got the questionnaire after the 3rd treatment. This is now the original, that's why it's in German. We try to document the age. We try to document problems, so they could give us here 1 or 2 or 3 or 7 problems. We try to ask and to get an answer how long they had these symptoms, and well, and then we try to understand and to get answers in the effect of the treatment by only putting a smiley scale here in vaginal dryness, in dyspareunia, in itching and burning, in dysuria, and in urge incontinence. At last, we try to learn something about stress incontinence or looseness, or and we try to find out about the costs like were they too high, and we charged our patients about 500 francs per treatment. So the outcome was that we have here, most of our patients were between 50 and 59 years old. So this is the point. And the second thing is they suffered from at least for 2 symptoms. They had at least 2 symptoms. And you see here, the major symptoms were, of course, as expected, the vaginal dryness, the dyspareunia, the burning itching, the urge, the stress incontinence, and the relaxation feelings, but not that present. And after 3 to 4 cycles, and the decision to do 1 cycle more or even 2 cycles more was made in a consent with the patient. And some patients, they complained that they still feel bad and they still have their problems, and so we try to add a cycle. The numbers are very small, so I can't tell you if it's really good to extend the treatment. So in my feeling, and sometimes yes, sometimes no, there were some women we treated, or I treated after an anti-hormonal therapy because of breast cancer, and they needed always more than 3 cycles to be satisfied, or to get the symptoms lower. And so we see some improvements here in vaginal dryness, which are really high, in dyspareunia, in burning, itching, in urge, also in stress, which was for me very well, not that expectable, and not really a high improvement in relaxation. But we saw that most of the women were satisfied and would recommend this therapy to other women. And that's what we see in our office. So we don't do a lot of advertising, and we have really a high recommendation percentage. So women come because they've been told that this is good, and this is a good treatment, and very well tolerated treatment, and it's a very effective treatment. And well, you see here that well, already 17 from 22 patients documented that for them that's okay to pay for that, and that's okay to pay this amount of money, and because for them this effect was very good, and they have a good life quality and improved. So just to answer the question, does it keep what it promises? Yes, but because I think that we should obey some perspectives, so we need an improvement in patient selection. So I wouldn't recommend a therapy, an intravaginal laser therapy, because of stress incontinence as a single symptom, because the improvement is not that high, and the benefit for the patient is, well, middle to low. As we saw in our patients here, the leading improvement, or the leading benefit, was really in vaginal dryness, and also in dyspareunia, and in burning, itching. So these are some criteria I would like to put in forward. And well, the second thing is we have a lack of documentation. We have worldwide a very low documentation rate. We don't have any studies which are really systemically done, And maybe we are someday able to create a nationwide well register or something, but I think it's too early to speculate for that, but it would be a first step to have this one. And we need more prospective comparative studies, and the problem in this case is that we don't have the financial basis for that, and we don't get any reimbursement, and I think the companies are not very easily to be convinced that they do a lot of prospective comparative studies. So that's what we need, and there are some studies on the way, but it's too early to talk about the results. And a very important thing is that almost in every patient, I had also I was also doing a lasering of the vulva, and especially in the dorsal entrance. So there, the dyspareunia and the itching and the problems and the injuries were very high, and I wouldn't do an intravaginal laser either without a vulvar laser. So I think these two should be together done because the benefit is higher then. And these are some considerations for the future, which I wish that we are able to establish. But for now, what we are doing is always only a questionnaire, but we are open for any ideas, and we are open for any dialogue for that, and we are able to do more. And also we would be happy if many colleagues are joining us, because I think that it's a very interesting treatment. It's a very effective treatment, and it's a treatment which should be in some line of treating patients with GUS. And the selection of the patient by the doctor will be always a different selection than it will be by the patient herself. So I personally think that the earlier we are getting in a medical setting in doing this, the better for the method, because the cosmetic settings will vanish, and they will go away. So that's why I would like to do it like that. So at last, I want to thank you for your attention, and I'm gladly open to ask your questions. So don't be shy if you want to know anything about our perspective or our approach to this interventional laser. You're invited to do so. Oh, okay. So I think there are no questions, right? I don't know if there are. But I can see that 15 people are here. Yeah.
Now there are questions in the question box.
There are questions in the question box. Okay.
Yes.
Here. Okay. Volume is fine. I'm sorry because I can't read these questions in my setting here.
There's a question. What is your experience with lichen?
Lichen. I tried only 2 patients yet with lichen, and both had a benefit, but not an objective benefit. Both I did a histology, and the histology was the same. So that's what we also see in patients if we do a histology of the vagina, like resecting some parts and give it to the pathologist. We really don't see an improvement in the cytology or in the histology, but the improvement was very subjective. Both of the women have less itching, less pain, and as I can see it now, it's not that old. It's about 6 months ago for the first one and 2 months ago for the second one. I see, I see really less injury. That's the point. I hope John Adam is satisfied with that, or if not, you're invited to ask back.
We have a next question. How many treatments are required to achieve a good result?
Yeah, I can say in our patients we did, the mean treatment was 3. 3 should be enough, but not in women who have the symptoms longer than 2-3 years. Then you need 4. So that's my experience. The next one.
Yes. How many patients have you been treating up to now? Did you encounter any complications?
Yes, I think that we have about 35 till now, and we didn't have any edema. We didn't have any pain. We did have one patient after a vulvar laser who had a small bleeding sensation, but that was all. So no grade 2 or 3 complication.
Okay.
So,
next question.
How long is one session lasting?
Yes, you see it. Okay.
Well, I have to admit that I was very, I mean, you know, at the beginning when you start to do something, I was very slow. So when I started, I had per session just for the laser treatment about 5 minutes. Now I'm doing the laser treatments in 2 to 3 minutes. It's going very fast. And the setting is also building up fast. So, and the benefit, I don't have any experience with RF. I'm not doing RF because I think RF is very painful. And I don't have the, I don't have the possibility, and I don't want to do RF for the tightening because in my opinion, you should have more side effects, John. So then I'm going just through how many times does it need between a session. I don't know what you mean, Alexei, but if you mean that between the sessions one to another patients to change, or between sessions in the same patient. In the same patients, we do it every 4 weeks, and changing time between the patients is, well, if you use a filter and you have to clean up the room, about 10 minutes. So, and well, then the second one, is it painful? We had, as I can't remember, I cannot remember one. No, I remember one, only one, who really told me that it was painful for her. I mean, she didn't interrupt the therapy, but and she had also a vaginism. I think this was the problem, but not the treatment. And the next one, in sexual medicine, vaginal laxity is considered as a pelvic floor muscle laxity. Where your patients reported. Yes, Jean-Jacques, this is what I think too, and that's why we are working in the pelvic floor now with a impulse method. We have a chair with a electromagnetic impulse, and so we don't work for laxity with the muscle, with the laser, and we work with the chair. And the last one in my thing, do you have an experience with intervaginal shockwave therapy? I don't know what you mean with shockwave. I don't have experience in that. I'm sorry. So, well, another one, or this was the last one?
I don't see another question, maybe? There is, but no, I think you have answered all questions.
Yes, I think too. I went through it. If there's something, or if you have questions, I mean, questions anytime. I think the company does have my email, or you too, and you can mail me or call me, and I'd be glad to get in a dialogue, because it's better when to be in a dialogue if you do a therapy, so we can only learn from each other. So, if there's no question further on, and I don't think that it is, because I don't see any hands, or thank you, John, for the comment. Well, if there are not any questions anymore, I want to thank you all for your time, and thank again the inviters for the presentation, and I hope maybe to see you in another webinar or in another Congress meeting, or wherever. It's a little bit difficult in these times. So I wish you all a nice evening. Have a good time, and well, maybe we see each other sometime. Bye-bye. Thank you very much for listening.